Mr. Chairman, Co-Chairman, ladies and gentlemen, my name is Thitiphon W from Ramathipati Hospital. First of all, I would like to thank TOSSM for having me here. Today I will talk about the cartilage injuries in athletes. Slide please, thank you. Here's my outlines. I will talk about incidents, evaluation, classification, management, and my example case. As you know, there are many sports competitions nowadays, and every athlete take it seriously. Of course, their joints exposed to more significant stress, and you already know that the cartilage is lack of spontaneous healing that may lead to functional impairment and limit the sports participation. For the joint involvement is more common in the weight-bearing joint with more symptoms and more percentage. The most common joint involvement is the knee, and the cartilage injury in athletes account for 36 to 38% of the knee injuries. For the most common side, the patellofemoral is the most common side, account for 37%. For the PF, the patellar side is more common than the trochlear. And for the femur, the medial femoral condyle is more common than the lateral femoral condyle. And also the associated injury, we found the associated meniscus injury approximately nearly 50%. So the cartilage injury is varied. It can present in swelling, in pain, locking, catching, or in combination, or even asymptomatic, which is majority. So the physician have a role to diagnose and to confirm with the investigation and decide whether the lesion, the clinical, correlate with the radiographic finding. For the classification, we normally use the outer bridge and someone use ICRS, but which is quite similar. The softening, the fraying of the cartilage, grade 2 with less than 50%, grade 3 with more than grade 50%, and grade 4 exposed to subchondral bone or involvement of the subchondral bone injury. The treatment could be conservative and operative. There are many factors that need to be considered before you give a treatment. First of all, it's about the lesion. How large is the size, where is the location of the lesion, and the severity, the grading. And also the patients, there are athletes, especially professional athletes, the age is crucial. And also the previous injury, if there is previous injury, it's the negative effect for the outcomes. And the competitive level is very important. Apart from that, we have to consider the associated injury. If there is some injuries, malalignment, or instability that needs to be correct, this maybe operative treatment is the answer. And the timing is crucial because the timing from injury to the treatment will correlate with the result. The less time from injury to treatment, the better outcome you will have. And of course, one more thing we have to consider is the season period. It's in the season, it's off season, it's affect our decision making. For conservative treatment, we have physical therapy, medications, supplements, and the injection, which many choice, the corticosteroid, HA, or orthobiologic. I will not go in detail about this because our next speaker will discuss about this. Of course, the conservative is the first line of treatment, except for if there is a mechanical symptoms such as locking or catching, or there's a loss of function or disability, the concomitant pathology that needs to be correct, or failure of the conservative treatment, or if you have a follow-up and there is a deterioration of the clinical or radiological findings, that's the indication for surgery. Okay, for the options of the operative treatment, we have the classic procedure, as you already know, the arthroscopic debridement with chondroplasty, the marrow stimulation microfracture, the matrix-induced autologous chondrocyte implantation, ACI or MACI, and the osteochondral allograft or autograft transplantation, which abbreviation by OAT or OCA. And there are many novel procedures upcoming nowadays, but the highlights, the AMIC and BMAC, which our next speaker will go in detail about this. For arthroscopic debridement and chondroplasty, the advantage is the rapid symptomatic relief and with a low cost and low morbidity. And it has a fast rehabilitation and shorter period for return to play. But it's just the only short-term relief. It's just temporary symptomatic relief. So indication is the lower grade, lower injury, lower severity of the injury, grade 1 or grade 2 injury of the cartilage within the small lesion. We mainly use it during the season because it's just a temporary relief. For the outcomes, it shows improve the functional score, KOOS, for small lesion, but it's not good for larger lesion. For microfracture, it's the bone marrow stimulation. So the tissue you got is a fibrocartilage, which has the less durability than normal cartilage. For the indication, is the first line treatment for the small lesion with just the chondral involvement, no subchondral involvement. For the result, it shows significant improvement of the baseline function outcomes, the functional score at 1 year, but with the shorter return to play period. But the clinical will got worse after 2 years. Next, it's a matrix-induced autologous chondrocyte implantation, MACI or ACI. Nowadays, it's the third generation using the biodegradable membrane or scaffold. The tissue you got, it will be the hindline cartilage, just like normal. So for the indication, it was indicated in the medium to large cartilage lesion with a depth of more than 8 millimeter. And the other indication is the chondral, either chondral or subchondral defect that failed to other repair procedure. The results show that it has significant improvement for the functional score at 1 year or so in the professional athletes. It has superior results compared with the microfracture with good to excellent results in the player at 2 years and low revision rates. And for the size of the MACI, the femoral chondral lesions have a better result than the patellofemoral. For the osteochondral autograft and allograft transplantation, OAT or OCA, it's indicated in the small to medium size of the cartilage lesion with subchondral bone involvement. OAT is better for the lesion less than 2 square centimeter. But for the OCA, it can be used in small or larger lesion. But there is some other aspect of concern because in some countries, the insurance will not allow to use OCA for small lesion. They will pay just for the medium to large lesion. So that's the other point. For the result, there is no comparative study between the pre-cut OCA and OAT nowadays. But OCA is preferable over OAT for the patellofemoral joints because it has the better contour matching and we can choose the cartilage thickness to match the patellofemoral. With the current evidence, the small lesion improved the outcome for the microfracture, the OAT, and AMIC and BMAC that Dr. Mant will talk about it later. And for the medium and large lesion, MACI and the osteochondral transplantation provide a longer durability and the higher return to sport rates. And MACI and OAT are recommended for osteochondral lesions. There are many treatment algorithms nowadays. Just for the focal lesion, if there's no associated injuries that need to be correct, for the athletes, we have a 1 and 2 square centimeter as a cut point for small, medium, and large lesion. And from that point, we have to check whether there is a subchondral bone involvement. if there is just the chondral lesion for small, the microfracture is the choice. But if the osteochondral involvement, the OAT is considered. For the medium lesion, the OAT and ACI is the choice for osteochondral involvement, but if it's just the chondral lesion, we have to check whether the age of the patient, if they are young and at the beginning of the career, maybe we choose the OAT or ACI, but if there is just the last period of their career, maybe microfracture could be considered. And for the last lesion, ACI is the answer. This is the many options with our already checked for the evidence. There's classified into high level, intermediate level, and lower level of evidence that show the support for these kind of lesions. So mainly in the small to medium sized lesion without subchondral bone involvement, the microfracture, OAT, OCA, and ACI can all be used. But for the larger lesion, the OCA and ACI is the major. So I may conclude this for the algorithm for athletes. It should be considered as 1 or 2 centimeters. We have to consider the size, the bony involvement, and the age of the patients. For return to sport, the meta-analysis show that the OAT has the best rates of return to sport, even in the pre-injury level, with the shortest time of return to sport, followed by the microfracture for the return to sport period. Okay, there's run out of time, so I will skip my case. He had a popping sound with the locking knee, and the physical examination showed the tender at medial joint line with limit knee extension. The X-ray showed that there are some radiolucent area in the medial femoral condyle, and the MRI showed that there is a displaced osteochondral fragment from the medial femoral condyle, and it attached close to the PCL. So this case, I think he has already got the osteochondritis dissecant, which just displaced with the squatting position. So I performed the arthroscopic debridement with the osteochondral fragment removal. I prepared the base and removed the fragment at the PCL. This is a fragment, and I plan to go for OAT. And I prepared the set to harvest, and I have harvest from the medial femoral trochlea and fill in the defect here. And this is postoperative radiograph. And this is at 3 months after surgery, it's healed. Okay, for conclusion, for the athletes, we have to make the decision-making by athlete-centered decision-making process. The treatment should be tailor-made to athletes, considering many factors as I mentioned before. And we have to follow the evidence-based treatment algorithm. Timing is the key. The shorter time to treatment, the better result they will have, and readily return to sports as far as possible. Thank you.